Hi everyone, welcome to one of our May webinars in the APCHO series. This one is entitled Connecting the Dots Using Health Research for Evidence-Based Advocacy. I am Isha Weerasinghe. I'm the Director of Policy and Advocacy at APCHO, the Association of Asian Pacific Community Health Organizations, and we're really happy to have this webinar to really show how we can use data for local, state, and national-based advocacy. Just to do a little bit of housekeeping before we begin, you're on the GoToWebinar platform. You should have a control panel on the right-hand side of your screen, or it might be on the left-hand side of the screen, depending on your computer. Within that, you will have the option to input any questions that you might have. During the remainder of this broadcast, all of attendees will be in listen-only mode. But if you have any questions, please type in your questions in that question box, and we'll go ahead and get started. So today we have two great speakers for you all. First is Dr. Naumi Feldman, who's the Director of Research and Evaluation at the Charles B. Wang Community Health Center in New York City. And then Naumi's presentation will be followed by Karuna Ramachandran's presentation, who is the Health Programs Director of CPACS, the Center of Pan-Asian Community Services Incorporated, which is located in Atlanta, Georgia. So we're going to be talking about briefly about APCHO's links between research and policy advocacy and the importance of making those links. And then Naumi will be talking about smoking cessation research and the advocacy that Charles B. Wang Community Health Center has done in New York City. And then Karuna will be talking about advocacy for disaggregated data collection efforts that they've done and the partnerships that they've built in Atlanta. So first of all, within the APCHO's research and policy department, we've been making a concerted effort to link the amazing data that we have within the health center sphere with the policy advocacy efforts that we do on a day-to-day basis, whether it's with our member centers or nationally. So legislatively, we use a number of research fact sheets with our Hill meetings, with both allies on the Hill and those that we want to convince of the importance of addressing needs for APCHO member centers. And the importance of that research is, when we go to a Hill meeting, showing the number of patients that APCHO member centers serve makes much more of a difference than them just hearing about it broadly. And knowing how many patients are in poverty, for example, who are APCHO member patients, or how many patients are under Medicaid by state or by region is incredibly important. So we use that research and data as much as we can. And we've also used some of that data within our research committee called VIPER, comprised of a number of key researchers and health center leadership. We have used some of the data within that sphere to write letters to the House and Senate committees on whether it's the Senate Finance Committee or other committees as well, to relate the importance of the services that our member centers provide. Lately, we've been doing more administrative advocacy, so we have used CHARN data, some of those more granular data sets for comment letters, for example, on Medicare preventive services, so ensuring that Medicare covers preventive services in Hep B screening. And we've also used data and specifically how certain member centers look at race and ethnicity for OMB comment letter that was commenting on the importance of disaggregating data on race and ethnicity across all federal agencies. So we just wanted to give you a snapshot of the kind of work that we do nationally and how we want to, it's incredibly important to integrate research and the policy advocacy work that we do. So from there, I'm going to hand it over to Naumi to talk about CBW's research.
Thank you, Isha. I'm Naumi Feldman. As Isha had indicated, I'm the Director of Research and Evaluation here at the Charles D. Wang Community Health Center. I want to thank APCHO and in particular Isha for inviting me to participate today in this webinar. This is a subject that's actually very near and dear to my heart because I'm not only a researcher, but in a former life, I used to be a health policy analyst within government, and I also used to be an advocacy director for a different community health center. So this is really an important subject for me personally, and I'm excited to have this opportunity to present today. Before I go on, I just wanted to indicate that I have no conflicts of interest to disclose. Okay. So before diving into an overview of our smoking research program and how our research has been translated into advocacy, I wanted to contextualize our work with respect to smoking-related policies in New York City and state over the past 15 years, as well as smoking trends among New Yorkers during that same period of time. So when former Mayor Michael Bloomberg first came into office as Mayor of New York City in 2002, along with his then Health Commissioner, Dr. Tom Frieden, the two had a very specific and clear public health agenda, which was to reduce smoking rates in New York City. Through a combination of legislative actions such as the Smoke-Free Air Act in 2002, which did what was then thought to be the unspeakable here in New York City, which was ban smoking in New York City bars, along with a number of tax-related strategies that raised the minimum price of a pack of cigarettes, as well as making free nicotine replacement therapy widely available, and ongoing anti-smoking social marketing campaigns. All of these actions have been part of an ongoing and persistent effort to combat smoking at both the local and state level. For some reason, Isha, it's not working. Okay, there we go. So this comprehensive ongoing strategy seems to have had some impact. Smoking rates have declined from 21.5% in 2002 to just over 14% in 2015 for all New York City adults aged 18 and older. And you can see that the trend here in this time series analysis of smoking prevalence for New York City overall between 2002 and 2015, there's been a small but fairly steady decline in smoking rates among all New York City adults during this period of time. But when we plot smoking prevalence for Asians in New York City during this same period, we don't see the same trend of declining rates over time. And even though we can see some dips in the timeline for Asians, the analysis of the linear timeline for Asians show no significant difference in smoking prevalence for Asians over time in New York City. But the analysis for Asians overall doesn't show the complete picture of smoking rates in this population in New York City. We know here at CBW that there are substantially more male patients who smoke than female patients. And in fact, when you can disaggregate the Asian smoking data by gender, the data also confirms what we see at our health center, which is that smoking rates have not only remained persistently high among Asian smokers in New York City, but also the vast majority of Asian smokers are in fact men. So before going into some detail about some of our research activities here at the Health Center, I thought I would just take a moment to briefly describe patient smoking patterns as well as some of our cessation programs here at the Charles D. Wang Community Health Center. For those who are not familiar with our health center, we are an FQHC that was founded in 1971. In 2017, we served just over 52,000 patients, And we have 5 locations in New York, 3 in Lower Manhattan in the Chinatown neighborhood, as well as 2 sites in Flushing. In 2016, 94% of our patients self-identified as Asian. 88% of our patients were best served in a language other than English. And 73% of our patients had household income levels of less than or equal to 100% of the federal poverty level. Last year, we also conducted nearly 31,000 tobacco use screenings, and over 1,400 of our patients were diagnosed that year as current smokers. So in 2015, we received funding from the RCHN Foundation to implement a bilingual smoking cessation coaching program, which offers regular in-person and phone-based counseling services over a 3-month period to smokers referred to this program, as well as offering free NRT for those who don't have insurance coverage for it. In addition, we also have a very robust health education program that's focused on smoking cessation. We've developed numerous smoking-related health education materials based on not only evidence from the literature, but also our own patients' beliefs, attitudes, knowledge, and behaviors. For example, we did a survey last spring, about a year ago, with a small sample of patients who were smokers. And we found that while most were aware of the health impact of smoking, many were less aware of the benefits of quitting. We also identified as major motivators to quitting one's family as well as their children. And finally, the study showed that major barriers to quitting, such as included stress, boredom, and fitting in with their coworkers. And as a result of this survey that we conducted, we actually developed an anti-smoking video targeting our health center's primary smoking population, which are adult men. And in the interest of time, I can't actually show you the video today, but if you just go and search on YouTube, you'll be able to find this video, or if you want, just let me know and I can send any of you the link to the video. But it's really well done, and we actually have it streaming in not just our own health center waiting rooms, but also in doctors' waiting rooms that serve primarily Chinese language-speaking populations throughout New York City. So in addition to the programs that we offer here, as well as some of the research that I'm going to go into, I wanted to also briefly talk about the community partnership that we've been involved with to combat high smoking rates among Asian American New Yorkers. We frequently seek opportunities to do outreach at multiple levels, whether it's at the community level or with our peer providers, as well as with our elected officials and other policymakers. So we're actually a founding member of what is called the Anti-Tobacco Partnership. It's focused on reducing smoking rates specifically within the Asian American community in New York City, and we've collaborated with this partnership for several years on citywide and community-based strategies and activities to encourage smoking cessation among this population. And it's not just our health center. We have multiple stakeholders who are involved with this partnership, including NYU Hospital Center, as well as several community-based organizations, including Asian Americans for Equality and Korean Community Services. We have several provider groups involved, including the Chinese American Medical Society, the Chinese American Independent Practice Association. We also have our local health department as part of the partnership, as well as NYC Smoke Free, which is a citywide anti-smoking coalition. And we even have one of the larger insurers in New York State as part of our partnership, which is Health First. So one of the signature examples of our partnership's work to raise community awareness and advocate for smoking cessation resources was the co-organizing of the first ever North American Chinatown Smoke Free Day, which was held in 6 Chinatowns across North America, including in Lower Manhattan. So now I wanted to talk about research here around tobacco use and smoking cessation at our health center. So before I go into the specifics of our research activities, I wanted to share a conceptual model of our approach to smoking research and advocacy here at the Charles B. Wang Community Health Center. So we follow a classical framework where we're first identifying what is the health problem, which in this case is high smoking prevalence amongst Asian American patients at our health center, as well as in the greater community that we're part of. Then focusing on designing and implementing research projects that help us to better understand the magnitude of this problem. Then this is followed by developing policy positions here that are informed by not only what we're witnessing with our patients and within the greater community, but also validated by the research that we do here. And finally, developing and executing an advocacy agenda that promotes these policy positions. So in addition to our clinical services and programming and community activities that we're involved with, we've developed a tobacco use and cessation research program here over the past few years. In 2015, we conducted a prevalence study on smoking amongst our patients. And then, as I previously mentioned last spring, we did a survey with our patients on their attitudes towards smoking cessation. And then this coming summer, we are about to implement 3 different research projects. One is going to be an evaluation of our current bilingual smoking cessation coaching program. We're also going to be implementing a pilot study that's going to look at the use of financial incentives to encourage patients to participate in our coaching smoking cessation program and to try to encourage them to quit. And then we're also going to be doing a modified version of the youth risk behavior survey with our adolescent patients to look at not just a variety of risk behaviors, including tobacco use. We've also been working with our anti-tobacco partnership on trying to do some research. Last summer, we did a street intercept survey in Lower Manhattan, in Chinatown area, and in Sunset Park, Brooklyn. And the purpose of the survey was to interview New York City residents who identified as Asian American to learn more about if they were smokers, what their cigarette purchasing patterns were, their quit attempts, and as well as for the general public, their awareness of various smoking cessation resources such as a Smokers Quit Line or the New York State Smokers Quit Line, as well as exposure to anti-smoking messaging and attitudes towards smoke-free housing policies. This was done with 250 respondents, and it took place in the summer of between the months of June and August of last year. And there were a number of key findings from the study, but some that I wanted to highlight include one, that we found cheap cigarettes are widely available. New York City actually has a minimum legal price of $10.50 per pack of cigarettes. But we found through our survey that among smokers, the median price per pack was $6. And in fact, nearly 50% of the respondents in this survey who were smokers indicated that they purchased packs of cigarettes on average for $5 or less. We also found that awareness of smoking cessation resources such as ASQ or the New York Smokers Quit Line was associated with a greater likelihood for trying to quit in the last year. So 63% of those who knew about either of these quit lines actually attempted to quit in the last year, whereas 42% of those who didn't know about it attempted to quit. So we don't know exactly why there might be an association here, but there does seem to be a positive correlation between awareness of these resources and quit attempts. We also learned that overall there's just a very low awareness of either of these smoking resources. Only 25% had heard of either the Asian Smokers Quit Line or the New York State Smokers Quit Line, and these proportions were similar among both smokers and non-smokers. And the reason why it's important to know about whether or not even non-smokers are aware of this is because with our own research last summer, we found that amongst our smoking patient population that for them, the largest motivator to quit was actually their family. So if non-smokers in their family are aware of the various resources that might be out there, they might be good motivators to encourage smokers to quit. Finally, we also learned that a greater proportion of the English speakers who participated in our survey had heard of either of these quitline resources compared to Chinese respondents in the survey. So there's several policy implications as a result of some of the findings from our survey. First, one implication is that there seems to be a need for more and better targeted smoking cessation social marketing campaigns for Asian Americans. As I noted just now, there's a low awareness of these resources that are available to help smokers quit, and awareness of these resources does seem to be associated with a greater likelihood to try to quit. One finding, which I didn't report out, but also has a policy implication, is we asked respondents about their attitudes towards smoke-free housing specifically, and we found that a large majority of both non-smokers and smokers support smoke-free housing. And we feel it's important to support these types of policy and legislative efforts to promote smoke-free housing because it's not going to only positively impact the health of both smokers and non-smokers in households, but hopefully it'll help motivate smokers to quit by creating additional barriers and hopefully changing community norms around smoking. And then finally, what our research has suggested is that while the strategy of tax increases to decrease smoking has likely had an impact on smoking rates for New York City overall and for many non-Asian populations in New York City, this strategy seems to have had minimal impact on the Asian population in New York City since our survey found that cheap cigarettes seem to be widely available. So all this leads me to the heart of today's presentation, which is how we've been linking our data to our smoking cessation advocacy efforts. We're still in the process of crafting our advocacy agenda, but there are certain advocacy objectives that we have, which are either confirmed by or direct derivation of our tobacco use and cessation research studies. This includes seeking funding for community-based smoking cessation initiatives that target Asian smokers, programs like the one that we have here at our health center, which is currently grant funded. We're also seeking language equity and smoking cessation resources. Right now, there's a heavy focus on English language smoking resources and even some Spanish, but in New York State, there hasn't been as much of a focus on resources targeting Asians. So we're hoping to have resources put in place for the implementation of a culturally and linguistically competent and accessible smoking cessation social marketing campaign. We're also seeking better regulation of both licensed and unlicensed cigarette retailers, while there's been a focus on ensuring that licensed retailers are following the law with respect to selling cigarettes at or above the minimum price. There hasn't been a focus on unlicensed retailers, and that really seems to be particularly problematic for the Asian population who are smokers in New York City. And finally, we're looking for implementation of policies that promote smoke-free environments, such as smoke-free housing laws. So there are a number of activities that we've initiated here to promote our advocacy agenda. We first have been focused on our local legislative body, which is the New York City Council. We've met with leadership and staff to advocate for discretionary funding. We've also prepared a policy briefing for New York City Council Health Committee. And we've been testifying at public hearings, most recently on a package of tobacco control legislation. We've also been focused on our health department, which has been instrumental in sort of setting and promoting various policies around smoking cessation. We've met with staff at the health department to advocate for a mass reach health campaign targeting the ethnic media. And as a result of our reaching out to them, they have willingly joined our partnership. They've also done their own internal analysis of data that they have on Asian smokers in New York City. And as a result of us encouraging them to do this analysis, they confirmed through their data what we've been seeing, which is that there's a huge gender disparity in smoking among the Asian population. And then in fact, Asian smoking rates among Asian men is much higher than for New York City adults overall. And they've also, as a result of our advocacy, have started to have their own internal meetings about developing an ethnic media-focused mass reach campaign. And then finally, we've also been working with our provider associations in New York State and various insurance plans to try to encourage them to promote smoking cessation resources. We presented 2 years ago our internal prevalence study on smoking at the Chinese American Medical Society's Scientific Symposium, and as a result, they joined our partnership. They also co-sponsored the North America Chinatown Smoke Free Days with their chapters around the US and Canada. And we've also been meeting with local insurance plans such as Health First and Infinity to discuss how to better engage provider members to offer screening, cessation, and referral services for their smokers. And as a result of our work with the insurance plans, one insurance company, Health First, has joined our partnership, and they've also been very enthusiastic about us reaching out to their providers. So at an upcoming provider symposium, we're going to be speaking about our partnership and also our own health coaching program. And that's a lot of information, and I will leave it at that. And if there are any questions, I'll be happy to answer them later on in the webinar. Thank you.
Thank you so much, Naumi. So we are going to leave any questions that any of the attendees may have, any of you all may have, until the end of the presentation. So I'm going to give it over to Karuna next to talk about CPACS work on data research and advocacy.
Thanks, Isha. Again, my name is Karuna Ramachandran with CPACS, or Center for Pan-Asian Community Services. Very happy to be here with you all today to share a little bit about our efforts to collect data and how we've partnered strategically to get to that point, and how we've also moved towards using that to inform our advocacy efforts, to push for greater resources, and to inform our work at the Community Health Center. So just first to give you a little bit of context. So CPACS, our community center and our community health center, Cosmo, is located in the heart of what's literally called the International Village in Atlanta. And so it's an extremely diverse strip along this one major highway that's really well known in throughout Metro Atlanta and probably throughout Georgia for its diversity, for its unique businesses, diverse, residential aspects as well. What's really interesting about Atlanta, Metro Atlanta, and Georgia in overall is that it's not just this pocket of diversity anymore. Ever since the mid-90s, very diverse communities have been moving into Georgia from all parts of the country, and of course coming from international locations as well. And this part is not as widely known and understood. The visibility of our communities here in Georgia and throughout the Southeast, I would say, is very low. I think partly due to the suburban or rural sprawl of how we're situated in communities, so that visibility is very low. And of course, the data showing our presence here is very low. So folks aren't really aware that the API community in Georgia is growing very fast. It's the fastest growth in the nation, and in many counties we're seeing rapid expansion of our communities. And here's just another snapshot showing some of that population change in the Southeast and also here in Georgia. And when you look at some of the disaggregated data among Asian American groups, we even have some of the highest growth, for example, with Burmese community, and also very high with the Asian Indian community. And so our efforts around data collection and data disaggregation is very much around raising the visibility of our communities first and foremost, raising the awareness of our existence, and then getting into the weeds of what does that look like. It's in line with our mission to provide comprehensive health and social services and capacity building, but to do this in a very data-driven way. And so we do our best to have our efforts be data-informed, to collect data as much as possible, and to sort of push that back out to key stakeholders as much as we can. And so this is sort of our approach as an agency with direct services, advocacy, and capacity building. And so the direct service component, of course, includes our community health center, Cosmo, our community centers, which are located in 4 different counties. And so I'm going to share just a few examples of how we've partnered with folks to collect data, how we collect our own data internally and push that out, and some of the effects that we're starting to see, not only here in Metro Atlanta, but statewide. So just a little bit about research partnerships. You know, over the years, just really making intentional efforts to connect with larger institutions, Morehouse, Emory, Department of Public Health, Advancing Justice, as you'll see on the left here, just to collect data here locally in the metro area to push out the information about what's really going on with our population changes, and getting to specific issues as well. For example, in this report here, you'll see that, you know, we're really trying to bring focus on Asian American caregivers for those with developmental disabilities, and then looking at, you know, health equity and how different factors have impacted the health outcomes of Asian Americans in Metro Atlanta. The Community of Contrast report is really sort of like a collection of disaggregated data highlighting what Metro Atlanta communities look like. And it's very interesting that when we do share this with our local partners at various levels, whether it be state organizations, whether it be our foundation partners, whether it's community leaders as well, folks still tend to be pretty surprised with the diversity and the numbers of our communities here. And so we continue to try to partner with these larger institutions to garner this data moving forward as well. Internally, we've done a lot of work to collect our own disaggregated data, and I'm sharing here just an example from our substance abuse prevention work. Our coalition, Georgia Team Empowerment, kind of has this tagline of bringing prevention to immigrant and refugee communities of Georgia. So again, the issue around building capacity to address substance abuse issues in our local communities really starts with first bringing attention to our existence, and then second to the specific issues that we're facing when it comes to substance abuse. And so in one of our campaigns here on the right, we focused on positive social norms around underage drinking and the sort of parental factors that impact supervision and norms around drinking in the household. And so this was a great opportunity for us to push it out to a wider national community when we presented the data at APHA in 2015. And it was very interesting to present this data to a mostly non-Asian group there. And again, the findings were really well received. We do see distinct differences among, you know, parental perceptions of underage drinking. And so this is just a, you know, kind of a small example of how we have used our efforts to collect disaggregated data and then push that out. And then specifically with this initiative, alcohol prevention, and as well as our tobacco use prevention and cessation work, we've used that to really advocate to our state partners in a couple of different ways. One, again, as part of a statewide initiative to address alcohol, we've really had to do that legwork to show our funders and our partners that by focusing on the Asian American community in our local communities, we will be making an environmental impact. And so we've had to do our work to collect huge amounts of data to show, again, the existence, again, the issue with underage drinking and tobacco use in the communities, so that our funders can then really support our initiatives to focus on these communities. Whereas when you look at what's going on statewide with some of our other partners, the focus would be primarily, based on English-speaking and perhaps Spanish-speaking communities. And again, just referring to some of our efforts in partnership with the state, we are partnered with the Department of Public Health to collect data in our local communities around the retail availability of tobacco. We're also working on developing statewide campaigns to address some of the issues of availability, cost being one of them. Unfortunately, the cost is still quite low in Georgia. And so, we took this opportunity to collect data on our communities again, but then to bring, a culturally specific focus to our data collection. Whereas, we could have easily gone out and just collected data on sort of what you see as like mainstream tobacco products. We know anecdotally that there's a lot of issue in our community with cultural forms of tobacco. And so in order to really be informed in our work, we wanted to collect that data using the resource and momentum with the state. And so here is just some of, the photographs just indicating that we were collecting data around gudkha and pan masala, which is actually more widely used in some of our communities than traditional tobacco. And so in our efforts across statewide partnerships, we try to bring that culturally specific focus. And then just sharing some photographs as well around our hepatitis B initiatives, like many of the other partners on the call, collecting data, running testing events, and making sure that we are collecting disaggregated data from communities around hepatitis B. Our effort is also, again, to make sure that statewide efforts around hepatitis don't have sort of this mainstream focus only. And so a lot of our research efforts, and this is sort of, in the beginning phases, but a lot of our research efforts are focused around sort of the cultural issues impacting testing, impacting vaccination. What are the specific healthcare access issues that might impact our communities more? And so bringing that again to the table so that as we participate in these statewide efforts, we're not losing focus on our communities. Couple of examples here with our cancer survivorship work and our senior services. So on the right, you'll see a report that was provided around our aging services here at CPACS. And, the advocacy work that we've done on the state level has really shown to help expand our work here at CPACS and really garner those resources to do so. So initially just serving Korean seniors here at the center, and through consistent data collection efforts and pushing reports such as what you see on the screen, we're now able to work with our Metro Atlanta Planning Regional Commission to garner resources to serve seniors 5 days a week. And so that's just an example of how, a consistent conversation that's data informed with our statewide leadership has led to increased resources here at our community center, so that now we have senior services not only for our Korean community, but also for our Vietnamese, Chinese, Burmese, and Bhutanese communities. And then on the left, just sharing a photo here of our cancer survivorship group. CPACS and Cosmo runs breast health screenings through our community health center. And part of our referral pattern is to utilize our own cancer survivorship support groups for Chinese and Korean women. And so we make sure that our patients have that full referral pattern all the way through survivorship support. Over the years, really just making sure that we have space at the table when we're talking about cancer survivorship and the needs of cancer survivors at a state level. And so in 2014, the state working group that sort of functions alongside our cancer control group initiated a needs assessment to sort of look at some of the emotional and physical health needs of cancer survivors. And what we saw from that data, what that group saw from that data was that it really wasn't very informative of what's going on with diverse communities or disparate groups. And so just this is another example of how we sort of really work hard to be at the table, to be part of the conversation. And now moving forward, this needs assessment is going to be reissued in the next couple of months, including translated surveys for the Chinese, Vietnamese, and Korean groups, as well as for the Latinx groups. And, you know, we really, you know, attribute that to, again, just consistently having those conversations with our statewide partners, consistently sharing the evidence from our own programs, sharing at conferences where cancer survivorship has been discussed, and highlighting the need to have a really focused effort on research with these disparate groups. And so we're really excited moving forward to participate with the statewide group and collecting this data with Chinese, Korean, and Vietnamese cancer survivors across the state. So sharing an example here, kind of a fun example as well, of how we've integrated sort of data advocacy in some of our community mobilization efforts. And so here's just an example of how we've taken our largest civic engagement event, which is TWalk, and we had a focus on data disaggregation. And this really helped us sort of, you know, have that conversation in the community about, you know, we count our specific story really counts, and that we have to make ourselves heard. And so using that as part of the advocacy efforts to the following year for Rocking the Vote, making sure that folks are inspired and motivated to get out and register, and then consequently to vote in the 2017 election. So we've kind of made that consistent effort through our community events to mobilize community towards data collection. And then here, just sharing a couple of examples around training and capacity building. We were able to host here in Metro Atlanta the first Language Access Summit here in Georgia that brought together many different stakeholders in Gwinnett County. If you'll recall earlier, Gwinnett County is one of those counties here in Georgia that's sort of exploding with AAPI population. And so in partnership with Gwinnett County, we co-sponsored this Language Access Summit, which brought together with Gwinnett County Fire, Gwinnett County Police. It brought together interpretation translation professionals to do training for the community service folks. And so we're able to really incorporate that data advocacy piece into different aspects of community work and different aspects of county administration. And so we're really just talking in our breakout sessions of how these individual departments across the county can think about how they can contribute to this effort of data disaggregation, and how that if they do not participate in that process, how does that really impact and really limit their ability to provide language accessible services. And then that's something that we incorporate ongoing in our cultural competency trainings that we provide across the state, is to ensure that all of our training attendees leave with a firm understanding of how this aspect of data collection and data disaggregation is really important for them to incorporate into their work in order to be culturally competent, and again, to provide those language accessible services. Over the years, we've provided census trainings for our community-based providers, our partners. We've brought together different stakeholder groups to work with census to kind of, again, just think about how we're using data. And then in conjunction with some of our healthcare advocacy work, sort of in alignment with ACA and Section 1557, again, thinking about how data really informs our efforts to prevent discrimination in healthcare settings. Simply as simple as, you know, having a language access plan at a healthcare setting really requires that organization put the efforts and the resources into studying the populations of focus and building their language access plan around that data. I'm going to just share a little bit around stakeholder engagement. I think this part is really critical for our work here in Georgia because, again, you know, we are really focused on that first stage as well of visibility. And so here are just some examples of how we've worked to make sure that our community's voices are heard, and that as we're having our presence heard, as our voices being heard, that we're really pushing that that data disaggregation agenda and the language access agenda. And so just a couple of pictures here of some events. The AAPI Lobby Day, where we were able to bring together several hundred folks from across the state to talk to legislators and with support of our governor to just really bring focus to the various issues that are impacting our communities disproportionately. We've also worked with CMS to bring together stakeholders to really discuss the ACA, to discuss open enrollment and how we can make the open enrollment process more language accessible and the enrollment process more culturally competent as well. And through some of that work with CMS, we've been able to push for more translation of their products as well. And then, you know, just in alignment with some of our, you know, Protect Our Care efforts, you know, really pushing out the need to advocate for our communities and our healthcare rights to specific populations. And so with the event Our Health, Our Rights, what we did here was really bring together specific media stakeholders in the Chinese, Korean, Latinx, and Vietnamese communities to really push out what are some of the broad healthcare issues and healthcare access issues that currently exist and how that could, you know, be impacted by some of the legislation that's being proposed. And so again, you know, just making sure that individual communities are really aware of how specific legislation will impact their communities and that they're empowered to then speak out about their communities and share those stories. And so that's been sort of the effort around our data advocacy, around our effort to collect our own data, to partner with large institutions to sort of impact their data collection efforts, and to make sure that when resources are being implemented into large-scale data collection efforts, that they're really making sure to disaggregate that data. And so I will just end my presentation there, and I'll be happy to answer any questions that folks have.
Thank you so much, Karna. So we're going to move into the Q&A section. So I'm gonna give you all a couple of minutes to think about some questions that you might have, and please feel free to put those questions into the chat box or in the question box. I think, and while you're doing that, we have about 10 minutes to for the Q&A session. I have a couple of questions for both Naumi and Karna, so I'll go ahead and ask until you all have some questions of your own. So one question I had was for both of you. Were there any barriers that you faced to help your health center understand the importance of either the smoking cessation or the data disaggregation, health disparity language access, cultural competency efforts? And how did you work to overcome that?
That's a great question, Isha. I feel like here smoking cessation has really been a sort of persistent long-term issue for our patient population that the health center has been aware of. We actually have, we have sort of a robust and well-established hepatitis B prevention and treatment program here at the health center. But, equally persistent public health and clinical issue has been high smoking rates for our patient population. And so this is something that I think our health center is starting to recognize more and more. So I wouldn't say that there's necessarily barriers, but we're really in certain ways in kind of like the nascent stages of addressing this and really trying to develop what we do here, both in terms of the clinical and more programmatic services that we provide, as well as our research and advocacy program. And I think everything kind of complements each other. So a lot of it is, we're a fairly big health center. And so a lot of this is really just about making sure that different parts of the departments in the health center that have, that focus in a different way around this issue, that we all kind of do our best to work together and to make sure that we're all sort of coordinated and we're really leveraging each other's work to really try to have a very comprehensive program in place. So I wouldn't say there's like necessarily barriers here, but it's a lot about making sure that the clinical work that we're doing, the health education work that we're doing, the research, as well as our policy and advocacy work, that we're all sort of aware of each other and on the same page, and we're working together as much as we can to put our best foot forward. So I think that's really where we're at right now in terms of doing smoking-related research and policy advocacy.
Thank you. And I have another follow-up question for you, Naumi, that we got from the audience. The question is, what type of staff are involved in Charles B. Wang's smoking advocacy work?
Well, really at the helm is actually our the executive vice president for external affairs, who is basically one of the hats that she wears is also as development director. But she's her name's Regina Lee, and I don't know if other members on this call are familiar with her, but she really has dedicated her decades of her life to doing health disparities advocacy. So she's really sort of the consummate advocate, and she's really taken this on as almost a personal issue for her. And so she's really been kind of spearheading this effort. And then we also have our health education team. They do a lot of advocacy work as well because of sort of the natural outreach and education role that they play here at the health center. So they've been involved with this, and also as well as our research department, we've really been trying to do research that really can be leveraged and utilized in terms of our policy advocacy work at the health center. So I would say it's a combination of our executive team, executive leadership, as well as our health education team and our research team. And I should of course throw in there our providers as well. They're really dedicated champions around the issue of smoking cessation. So it's been a coordinated effort here at the health center.
Thank you. Karuna, do you have anything you want to add to the barriers question and how a health center can go about integrating data and advocacy?
Yeah, absolutely. Similar to what Naumi expressed, I wouldn't say that we have internal barriers around understanding the importance of collecting the data and using it for our advocacy efforts. I think probably like some other members on the call, the true barrier is around our capacity to do that. And so when we think about collecting data from rich data from our patient population, we really have to use our health educators and our patient navigators, as well as our community outreach workers, to do a lot of that work. And they are very inundated with a very high patient load. And so, there's so much interest in collecting the data from our providers, our, administration of the organization, and certainly on the community center side. The issue really comes back to capacity for us. And that's where some of our strategic partnerships with larger institutions, for example, we're going to be partnering with Emory moving forward. And this is something I left out from our presentation, but Emory University is going to conduct a tobacco study for us. And so that information can then feed into our efforts at the community center. But really, in order to make that happen, our community center has to leverage external resources at this time. And so there's no shame in that. And we certainly are always looking for opportunities to do that so that we can expand our own internal capacity moving forward.
Thanks, Karuna. So I have, since this is also a very personal interest of mine, I have a bunch more questions, but we only have 3 more minutes. So I'm going to just skip to the overarching question, which is, what would you both give in terms of advice to other health centers who may not have as robust of a program on the research or policy side? What advice would you give to those health centers in trying to start and getting their feet off the ground to start integrating research and policy together?
Oh gosh, that's a great question. I think it's kind of, in some ways, we're so fortunate here at the health center to have a research department, albeit it is small, but we are a team of 3 full-time staff. But I realize that most health centers don't have that type of resource on hand, but they do a lot of QA work, and I think that in and of itself really is research and rich data that health centers can work with to try to sort of push forward issues that are near and dear to their health center and their patients. And I think a lot of it really comes down to finding champions within your health center. Unfortunately, all of the health centers and nonprofits it's always going to be, as Karuna suggested, a capacity issue. And so it's really, a lot of it is about finding someone who is just going to champion the issue and take it on because it's really important to them, and that they're going to try to find the time that they can to dedicate to it. But it is hard, I think, and of course a lot of it is really making sure that senior leadership is behind the cause as well, because you really need support at all levels in order to push forward these types of initiatives.
Yeah, I would definitely echo that. And I think that, you have to have the strong support of your health center administration and your QI committee and your, in order to really push for integrating data collection into your health center processes. And so I think that's like a very important first step. So if there interesting points of data that you want to collect, it's really important to have that integrated into everyone's workflow appropriately and realistically. And then I also think that many of the member health centers have this community service sort of grassroots aspect to their work, if not all of them. And so I think every day there's an opportunity for data collection of some sort. And so really just thinking about all interactions as an opportunity to collect data. And again, you may not have a research department, like we currently do not have a research department, but you can leverage resources from universities or other larger institutions like state departments of health to, maybe get interns or feed into their projects to use your data and to get it out there. And so that's kind of what we've done, is to really just leverage those partnerships to have the projects move forward, so that our rich data doesn't just, sit on the shelf, that that can actually be used to inform efforts.
All right, with that, thank you both very much for sharing your innovative strategies and trying to integrate both research and the amazing work that you've done locally and statewide. And thank you for taking the time to present today. I have one more thing that I wanted to mention, is that we have 2 upcoming webinars, one on June 21st on eliminating viral hepatitis, which is going to be focused on the NASEM report, National Academies of Science, Engineering, and Medicine report on the elimination of hepatitis B and C. And then we have another webinar on June 27th, which is trying to figure out how to use National Health Center Week for advocacy purposes. So again, Karna and Naomi, thank you very, very much for presenting today. And for those on the call, we will look forward to speaking to you all about this work in the future. And this will also be recorded for future reference. Thank you.